Hello everyone, myself Dr. Suresh, and in this video we'll talk about the metabolic disorders related to aromatic amino acids, especially phenylalanine and tyrosine. So first to start with phenylketonuria. So we have seen in our previous videos how phenylalanine and tyrosine are metabolized and what are all the products are coming from these substances, right? So if there is any one of enzyme deficient or defect leads to various disorders, so we'll see one by one. To begin with phenylketonuria. So what is phenylketonuria? So here in conditions like phenylketonuria, there is inability in conversion of phenylalanine to tyrosine. Why? Because there is an enzyme deficiency called phenylalanine hydroxylase. Phenylalanine hydroxylase is an enzyme which converts phenylalanine to tyrosine. So I have said in the other videos that what is the mechanism of action of phenylalanine hydroxylase. Phenylalanine hydroxylase adds hydroxyl group to phenylalanine to convert to tyrosine, and it requires molecular oxygen. At the same time, it is tetrahydrobiopterin dependent enzyme. So tetrahydrobiopterin is a donor of hydrogens to add a hydroxyl group and is converted into dihydrobiopterin, and dihydrobiopterin again has to regenerate as tetrahydrobiopterin with the help of NADPH. So here NADPH dependent reductase which requires in regeneration of this. So if there is any defect of this enzyme, then there is inability in conversion of phenylalanine to tyrosine. So high levels of phenylalanine will be there, and they will take other alternative routes converted into ketogenic or acidic substances and start excreting in the urine. So that's why phenylketonuria. Okay, phenylalanine alone will not be there. Excess accumulated phenylalanine will take and divert metabolic pathways to produce ketogenic substances and acid substances. So they cause a condition phenylketonuria. So here, what are the other alternative pathways? You see here, when there is no conversion of phenylalanine to tyrosine, so there is alternative route to form phenylpyruvate. So this phenylpyruvate is converted again to phenylactate and phenylacetate. So these are the three substances, all are ketogenic in nature. Phenylpyruvate, phenylacetate, phenylactate, all are ketogenic in nature. So that's why these products will be excess in urine. So leads the condition phenylketonuria. You see here first, what is happening here, phenylalanine converted to phenylpyruvate. In this diagrammatic representation, so when you see the chemical reactions of phenylalanine, other metabolic fate of phenylalanine, excess amounts of phenylalanine, they will be converting into phenylpyruvate by transaminase enzyme, where alpha ketoglutarate accepts the amino group from phenylalanine converted to glutamate, and where it is phenylalanine converted to phenylpyruvate, and by reduction reaction phenylpyruvate converted to phenylactate, and phenylpyruvate will be converted into phenylacetate by decarboxylation, and this phenylacetate again converted into phenylacetyl glutamine. So phenylacetate is there, so the excess amounts of phenylacetate gives some characteristic mousy odor smell. Okay, if suppose a person suffering with phenylketonuria, okay, if he urinates at some place, okay, if you go near to that place stinks like mousy odor. Okay, and moreover, because of accumulation of phenylacetate in the body, so the person also stinks like in mousy odor. So what are the characteristics of phenylketonuria? So autosomal recessive it is in condition, and it is chance of 1 in 10,000 to 25,000 births, the chance of getting phenylketonuria. And clinical, to talk about clinical manifestations, the classical phenylketonuria child is mentally retarded with IQ of 50, so it is a dangerous condition. And agitation, hyperactivity, tremors, convulsions are often manifested in phenylketonuria. The child often has hypopigmentation because there is no conversion of tyrosine, and tyrosine cannot be converted into melanin. So that's the reason here hypopigmentation, explained by decreased availability of tyrosine for melanin production. Phenylacetic acid may lead to mousy body odor. So what are the laboratory diagnoses that exist as a diagnose phenylketonuria? So the blood phenylalanine levels, normal level is 1 mg per deciliter. In phenylketonuria, the level is less than 20 mg per deciliter. This may be demonstrated by chromatography, and tandem mass spectroscopy is also most reliable one to test phenylketonuria, but which is a costly one. And the most dependent is 𝐒𝐻𝐵 test, which is a rapid screening test by using bacterial inhibition assay. So in 𝐒𝐻𝐵 test, what they do, they will take a blood agar and then they will cultivate bacteria. So they will provide phenylalanines and other substances. So if high amount of phenylalanine, it acts as inhibitor of bacterial colony growth. Okay, if phenylalanine is not there, bacteria will grow. Okay, so by making this difference, you will detect phenylalanine in the blood. So we can use DNA probes which are now available to diagnose the phenylalanine hydroxylase deficiency. Ferric chloride test, urine of patient contains phenyl ketones and a drop of ferric chloride to the urine will detect the presence of phenylalanines, and transient blue-green color is a positive test for phenylketonuria. So what is the treatment of phenylketonuria? So low levels of phenylalanine in the diet, and as I already told you, here it is a condition phenylketonuria. So the first reaction, the inability in conversion of phenylalanine to tyrosine. So here we have to stop providing phenylalanine, start giving tyrosine. So the problem has been solved. So in this condition, the diet has to be restricted with phenylalanine, has to start with tyrosine. And phenylketonuria is a carrier state. It is a recessive gene, heterozygous condition. Phenylalanine low test will be positive. So the next disorder of this phenylalanine metabolism, that is 𝐒𝐽𝐵𝐷𝐼𝐴. So this 𝐒𝐽𝐵𝐷𝐼𝐴 mainly you can see in 𝐤𝐵𝐺𝐼𝐴 acid oxidase enzyme deficiency. So this is also autosomal recessive, 1 in 250,000 births. It's also inborn error of metabolism. Deficiency of the enzyme 𝐤𝐵𝐺𝐼𝐴 acid oxidase. And 𝐤𝐵𝐺𝐼𝐴 acid in blood excreted in the urine. So they may lead to very normal life, not like dangerous like phenylketonuria. So here blackening of urine on standing. Why? Because if you want to diagnose 𝐒𝐽𝐵𝐷𝐼𝐴 patient, you have to ask the patient to collect the urine in a test tube and allow the test tube to stand for 2 hours. Then what happened? This 𝐤𝐵𝐺𝐼𝐴 acid concentration in the urine, okay, reacts with the molecular oxygen in the air and turns the urine pale yellow color into dark black color. So that's why it is otherwise known as black urine disease. Okay, 𝐤𝐵𝐺𝐼𝐴 acid, okay, which is highly oxidative, highly reactive with the molecular oxygen in the air, converted into black in color. So blackening of urine on standing, and ferric chloride test is positive. Benedict's is also positive. Why? Because 𝐤𝐵𝐺𝐼𝐴 acid is strong reducing in nature, which can give positive to Benedict's test. Okay, Benedict's test, don't think that it is only positive for glucose. No, it is a test for reducing substances. Vitamin C also give positive for Benedict's test. Next to vitamin C, 𝐤𝐵𝐺𝐼𝐴 acid. Okay, don't think that glucose alone is the only confirmatory test for Benedict's test. Ochronosis. Why? Because as I said, ochronosis means blackening of invertebral disc, cartilages, joint cavities. Because why black deposits? 𝐤𝐵𝐺𝐼𝐴 acid when react with oxygen, it converts into black in color. Right. So in soft tissues, it will start accumulating. Okay, next to ear pinnae, cheeks. Okay, and corners of the nose. So at the intervertebral disc, the excess amounts of 𝐤𝐵𝐺𝐼𝐴 acid deposition and converts into black color. So if you see the thing here, the specimen on left which has been standing for 15 minutes shows some darkening at the surface due to the oxidation of 𝐤𝐵𝐺𝐼𝐴 acid. After 2 hours, the complete urine sample turns into black. So that's why 𝐒𝐽𝐵𝐷𝐼𝐴, otherwise known as black urine disease. So in babies, how to identify? If you see the diapers of the babies, when you are changing, there will be black stainings on the diapers. This way you can identify 𝐒𝐽𝐵𝐷𝐼𝐴. So next disorder, albinism. So you can see this 1 in 20,000 population. So we already learned that there is defect in melanin synthesis because the enzyme deficiency tyrosinase. Okay, so tyrosinase in absence, it cannot produce melanin. Okay, so albinism and leukoderma are different. Fundus iris, hypopigmented photophobia, nystagmus skin, sensitive to UV light melanoma. So these are all characteristics of albinism. So if you see the picture here, albinism in Indian boys and albino monkey and albino tigers. So they are all defect of the enzyme tyrosinase. Tyrosinemia. So what is tyrosinemia? Tyrosinemia is a condition where excess amounts of tyrosine you can see in the blood. Okay, because of the enzyme tyrosinase deficiency. Also you can say the deficiency of the enzyme fumarate acetoacetate hydroxylase, which cause type 1 tyrosinemia. Okay, there is a further degradation of tyrosine, and tyrosine aminotransferase is causing type 2 tyrosinemia. Okay, so because of these two enzymes deficiency, you will get tyrosinemias. So what it do? It causes mild mental retardation because tyrosine cannot be converting into catecholamines, right? So if there is no catecholamines, there will be mental retardation. This way you can convert, you can give the logic. Para-hydroxyphenylpyruvate you can see in the urine. Mild mental retardation, para-hydroxyphenylpyruvate in urine. Cirrhosis of liver, nephropathy, hypoglycemia, death in the early stage of life. So to summarize the tyrosine metabolism, the related disorders, you see here phenylketonuria 1, where there is a inability in conversion of tyrosine. and 2 where homogenistic acid oxidase deficiency, there is inability in conversion of homogenistic acid to mallyl esterase state where the accumulation of homogenistic acid causing 𝐒𝐽𝐵𝐾tenuria, and 3 hyperthyrosinemia you can see where fumarate esterase state cannot be converted into fumarate and esterase state, so that is also tyrosinemia type 1, and 4 that is albinism, absence of tyrosinase enzyme deficiency again, and tyrosine hydroxylase is a key enzyme epinephrine synthesis. Tyrosinemia type 2, absence of tyrosine transaminase, okay, tyrosine transaminase, so tyrosine cannot be converted into hydroxyphenylpyruvic acid, and this hydroxyphenylpyruvic acid you can see in excess amounts in urine. So the important product also I have covered here. So thyroxine hormone, catecholamines, skin pigment melanin, glucogenic substance, ketogenic substance, okay, dopa. So all these are the important things with the enzyme defects in this whole diagram I have covered. So that's all about the disorders related to aromatic amino acid, phenylalanine and tyrosine. Thanks for watching. Thank you.